you for inviting us to the consortium. My first experience as a partner in an EU project, and it was a very positive one, thanks to your leadership. You've been calm, intelligent, ethical, and in a project that is a minefield of complexities. So great admiration for you and for your colleagues in Verona. I will move to my presentation. So I will not do everything Corrado said. I won't be talking that much about WHO. I will give a global perspective. What I will not do is talk so much about asylum and refugees in Europe. I will, for the first time this year, not talk about COVID-19, or hardly. I will not talk about our leadership in the Interagency Standing Committee, the interagency work there, nor will I talk about our country work. I more generally like to put the Redefine project in a global policy, humanitarian policy context. Just sometimes I give presentations and after a while people say, what do you mean with humanitarian? But just to say, these are the situations that arise from conflict and natural disaster. Usually the amount of the needs are bigger than what can locally be provided. So there's a need for external assistance. Now, the numbers, we have new numbers this week. And anybody who's writing in this area, please know that all the numbers have dramatically changed because this week the UN has reported new numbers, and it's a 40% increase of people in the world that need humanitarian assistance, partly because of increased conflict, but also partly because of the impact of COVID-19. So there's now not, as we would say 4 or 5 years ago, 130 million, but there's 235 million people in need of assistance. And the number of refugees and the number of forcibly displaced is almost 80 million now. These are staggering numbers. Now, as I work for WHO, and when one works for a UN agency, one gets these really enormous questions from government, like what do we do for 1 million people who are in who are just in the middle of the crisis? So then it's a little bit difficult to just go to the Cochrane review and say, well, you know, intervention X works better than Y, so we take intervention X. There's the complexities are higher. Now, my PowerPoint jumped away. There it is. It's back here. Did I share my screen?
We cannot see the screen yet.
Ah, let me share the screen. It's much better. Voila.
Yeah, good.
Voila. Okay, but that's okay. The screen was not essential. So if you have you're in a setting and there's 1 million people and the government asks you, what do we do for 1 million people? What do? You say, well, we need to set some priorities. But there's different people who look at these priorities, will answer this different, right? So what would you do? Would you say, I'm going to set out to help everybody who is distressed? Are you going to say, I'm going to help everybody at a risk of a mental disorder? Are you going to say, I'm going to seek to help everybody with a mental disorder? With a severe mental disorder, only PTSD, only people who seek help. Different people will answer this question differently, and different excellent people will answer the question differently. But the answer is not simple. But I'll tell you what are not WHO views. WHO view is not to focus on well-being only. WHO view is not to prioritize post-traumatic stress disorder over other mental disorders. WHO view is not to ignore severe mental disorders or psychosis. And WHO's view is not to just look at the most effective interventions without consideration for cost or scalability. Let me just say, because I've talked a lot about mental disorders, that the mental health and psychosocial needs in humanitarian crisis are extremely diverse. People don't just have a mental disorder because of whatever reason. There's wide range of psychosocial problems. People are beset by problems with livelihoods, marginalization, discrimination, and there's a lot of social suffering. There is a lot of problems who were already there before the crisis, including social problems, psychological problems, psychiatric problems. All of that is part of a very complex context. Most common question we get is actually, how common are these mental disorders? And there is hundreds of studies in this area, and they have an absurd range of findings from 0%, their studies would say there's no mental disorder, to 99%. Everybody has a mental disorder. Those of you who are statistically inclined, just let me emphasize that there's enormous heterogeneity even within subgroups. So if you just look at the studies of the Syrians or people who were in certain parts of Africa, you still get enormous heterogeneity. The data are all over the place. Still, there's patterns, and higher quality surveys have, on average, lower rates. But there is a dose-response relationship. More adversity, more trauma, more loss, more bad things happening to people, higher rates of symptoms and disorder. And an unsupportive recovery environment, like bad security, higher rates of symptoms and disorder. We have worked with burden of disease experts using Bayesian meta-regression, trying to deal with the most complex, some of the heterogeneity issues within these data sets to estimate WHO projections. And these were published last year in the Lancet. And these are our estimates. Let me say, you see them on the screen. Let me say that I absolutely call these estimates and not facts. And there's lots of uncertainty around these kind of estimates, and they will vary from place to place, and definitely from assessment method to assessment method. Now, what is the general global humanitarian policy? Actually, the global humanitarian policy is not WHO. It comes from two sources: the Sphere Handbook, which is actually civil society handbook that overall describes the minimum standards of response in humanitarian settings, and the Interagency Standing Committee, which WHO indeed is part. And these are the two main sources for policy. And of course, we're going to see how the work of Redefine may fit in this work. I'm going to zoom in here on the Sphere work because it's more focused and easier to present, and I think it's a tighter set of recommendations. However, the Sphere recommendations focus very much, although it doesn't say so, in reality, it's very much a focus of acute emergencies. So let's say the first couple months that a new humanitarian situation exists and there's very little available. What are the minimum actions there? Obviously, when it's later on the response, more can be done. But even then, the minimum things should have been done or should be available. Typically, they're not. So what are the minimum things? So you need to know the minimum things everywhere, even if you're years in, because I tell you, usually the minimum is not there. So you should start getting the minimum in place. First of all, it's coordination. And the coordination in our area is exceptionally intersectoral. Exceptional because most of the needs of the people who are in the humanitarian settings a lot of their mental health concerns are driven by social determinants. And so protection, welfare, social welfare is hugely important. Livelihoods is hugely important. Supportive education safe education is really important. So the intersector and much of the mental health sector supports can happen through different sectors. So having this coordinated is complex, but that's the first action of the recommendation Sphere. The second one is needs assessment. But what is the key message here? It is probably not epidemiology that's going to give you the quickest and best information on how to set up your programs. The starting point is figuring out what the resources are. What are people doing? What are the resources of the community already to bring in to set up programs? The third point is about community self-help and social support. And often this work relates to helping people, getting them out of social isolation, supporting with livelihoods, and people helping each other. This is not the self-help plus that, although the word, many of you know the word self-help plus, and it will be mentioned much later in this today. This is a different type of self-help. Then, very famously, is the psychological first aid. And the key point here is that many people who go through horrible things, they get initial support that's actually unhelpful to them, that undermines their dignity, where they feel less supported than they already were. And psychological first aid gives a number of principles on how to avoid that and actually do the opposite and be supportive. The fifth part is a very clinical one. This is what should every health center be able to offer? Not mental health center, every health center, which is some basic form of clinical mental health care, the primary healthcare paradigm. And that means there needs to be clinicians trained in basic mental health care. And there needs to, and for some conditions, drugs are necessary. We see in the photo on the right, you see the kit that is being provided for medicines in emergencies. And there needs to be some guidance protocol. On the left, you see our MHCAP humanitarian protocol. So this is very much what happens in the clinic. The sixth, and that is making psychological interventions widely available for people impaired by prolonged distress. And this covers people with mental disorder, obviously. This has been a challenge, because if you just do mental health and primary healthcare, you'll probably miss a lot of people who never go to primary healthcare, who will never be identified in primary healthcare. So you need strategies beyond that. And the scale up of psychological interventions is something that is a central theme in the last 10, 15 years of global mental health discourse. It is like, how do we do this? And how do we make sure, are there interventions that are effective? Yes, there are. Are there manuals that can be simplified? Yes, there are. There's some photos of them here. But can we scale this up? And we will come back. I think this is going to be a common theme in today's how to do that, and Redefine has contributed to that. The seventh action is protecting the rights of people with severe mental health conditions in emergencies. So this is a photo of the mental hospital, what was the mental hospital in Aleppo in Syria. And there one can show photos of many places around the world where people with severe mental disorders are extreme risk in emergencies. They deserve protection, and they deserve also, obviously, better places to live than an institution. If I had more time, I could say much more about that, and opportunities there to provide better care for people with severe mental health conditions after emergencies. 8, completely forgotten, is in most places, is the issue of alcohol and drugs in humanitarian settings. The essential point here is actually that it's forgotten, and that the probably harm reduction is the first minimum type of support that needs to be initiated. And I would say worldwide, it's more alcohol than drugs. I mean, drugs is a huge issue, but alcohol is a vastly ignored issue in humanitarian settings. And then the 9th is taking the emergency as an opportunity to build back a better mental health system. And we have many examples of how to do that. And it's probably core to WHO's approach to emergencies to try and help the country make a shift, a leap forward out of the emergency because of the interest there. And I claim that if one looks at let's say the top 20 countries who have made progress in the last 20 years on mental health, top 20 low middle income countries who've made progress, that more than half have made that progress out of crisis. And that is an opportunity today for those of you who are thinking of COVID-19, that COVID-19 is a crisis for the world and is an opportunity for to get mental health much higher on the agenda, and to work and to get ministries of finance to finance mental health within health, to have a more appropriate funding scenario for mental health. Now, all of this is nice and beautiful, but there are some issues. So let's say this kind of policy that I described has been around for a while. But if you look in the reality, what happens in a humanitarian setting, and you make a map and you start mapping what is being done, you don't get such a beautiful thing as these 9 things implemented everywhere. No, you get like, okay, in one place in the north of the district or the area, people are working on one type of intervention, let's say psychological first aid, while in another place in the west, they may be doing community supports, or another place they may do psychological interventions, and then in the south, they may do integrated mental health and primary healthcare. It's all beautiful, but if you live in the wrong place, and your needs may not be met because the type of intervention may just not be the one that you needed. You needed them all. So what happens is that there is it's a little chaotic offer of different supports, and rather than a planning of what are really the minimum ones, and can we make sure those are available everywhere? That's a public health approach. So WHO, UNICEF, and UNHCR are now working together on a minimum service package that will be costed and try to move towards this approach where everyone everywhere can get an equitable access to these short list of interventions. The second big problem, which is not only a problem for humanitarian settings, but a problem for development in general, is that we vastly miss care for depression, anxiety, PTSD, etc. So there is just very little, most people with an anxiety disorder or depression are not going to get the care they need. And that is even higher in humanitarian settings, because there's much more emotional disorder, much more depression, anxiety, and all that. So there is a need for scalable interventions, and the general consensus is that that is likely will have to come through psychological interventions, not through medicines. And that it will have to move beyond classic approaches where you have the psychologist sitting in the clinic waiting for people to come. That this, for scale up, it needs to be beyond specialists. It needs to be innovative. Technology can get involved. It must be is an opportunity, and one needs to think out of the box. And that this work needs to be rigorously tested in order to make it worth the investment. Now, there has been a number of large efforts to research this work so that it can be easier to make sure that there's interventions that are scaled. And WHO has been very active in this area, but we're not the only. There's other groups who do excellent work in this area. And but the hope is that we will arrive at a set of psychological interventions that are so easily implementable that they will actually be scaled, and while being scaled, still being effective. That is the objective, and so scalable that they can actually cover large areas where people live, and so that there's an equitable access. Now, there's a number of consortia. The EU has now funded 3 consortia that work in this area: Redefine, discussed today, Strengths, and Response. And also, there is the R28C, which is a research funder that has funded a lot of work in this area, including quite a bit of WHO research on psychological, scalable psychological interventions, but also many on those of other agencies who work independently of WHO or with WHO. And if you think back on the 9 items in Sphere, there was one of them on psychological interventions. And that is one where the initiation of the psychological interventions should happen early in emergencies, but the scale up later on. Certainly in the refugee response and in the displaced person response around the world, it is really important that we learn to scale. Further comment is that, the Redefine work is different from the other work in that it has a focus not on treating mental disorders, but on preventing mental disorders in those who are already distressed. Indicated prevention. And I'm very proud to say that this, in my view, is the first work ever done that properly researches this by properly measuring the incidence of mental disorders in the group that gets the prevention intervention and the group that doesn't get the prevention intervention. This has been done before, but never in humanitarian, in people affected by humanitarian crisis. And there's a huge need for that. So I'm really pleased that the EU Redefine project and the University of Verona in the lead has taken this on and brought us some good science to build on in future years. Thank you very much.